12 o'clock. So we will get started. I am Nicole Pang, and I am the Policy and Advocacy Coordinator with the Pennsylvania Coalition for Oral Health, and I am delighted to welcome you to today's webinar, Dental License Portability in Pennsylvania, Unlocking Opportunities. Before we dig in, a few housekeeping notes. Please remember to keep microphones muted to minimize any background noise. Also, there will be time dedicated at the end of the webinar for questions and answers. So please make sure to use the Q&A feature located at the bottom of your screen throughout today's presentation. Additionally, we are recording this presentation and slides will be shared with registrants after the event. Next. There has been a slight change to today's agenda due to unforeseen circumstances. A member of the PA Board of Professional and Occupational Affairs is no longer able to join us. However, we will still be providing a brief overview of Act 41. Today, we will begin with an outlook on the oral health workforce in Pennsylvania and continue by exploring current and proposed licensure portability avenues that will play a crucial role in shaping the landscape of Pennsylvania's dental workforce. Next. We know that providers are disproportionately concentrated in urban and suburban areas in the southeastern and southwestern parts of the state. This pattern of distribution contributes to the current disparities in access to dental care. And as of December 2023, the Health Resources Service Administration identified 174 dental health professional shortage areas, representing over 2 million individuals without access to dental care. The shortage of dentists in the state is expected to continue on a downward trend through 2030, furthering the already present impact of too few providers. And we are witnessing this through the extended wait times for appointments. On average, patients have to wait 55 days for a new visit, and this duration nearly doubles for those relying on federally qualified health centers. Now, Pennsylvania does have 4 dental schools and 13 hygiene programs. However, this educational infrastructure alone is insufficient to address the pressing concerns within our workforce pipeline. One opportunity and the focus of today's conversation is to address the workforce gap by easing the ability for out-of-state dental providers to practice in Pennsylvania. Next. Addressing the oral health workforce in Pennsylvania is not just important for PCOH, but it is an identified priority in the Pennsylvania Department of Health's 2020-2030 Pennsylvania Oral Health Plan. The Oral Health Plan highlights Pennsylvania's need to engage in strategies that promote a sufficient and diverse workforce focused on addressing health promotion, quality of care, and disease prevention. Next. To assist us in exploring possible strategies to meet these goals, I'm very excited to introduce today's speakers who will be educating us about 2 dental licensure compacts. Dr. Arthur G., Vice President of the American Association of Dental Boards, will be discussing the AADB's Dental and Dental Hygiene Licensure Compact, followed by Mr. Matt Schaefer from the National Center for Interstate Compacts, who will be discussing the Council of State Governments Dentist and Dental Hygienist Licensure Compact. But before we delve into that, please welcome Helen Hockey, Executive Director of the Pennsylvania Coalition for Oral Health, who will be providing a quick look at Act 41 and PA's current license reciprocity process.
All right. Hi, everybody. Thank you, Nicole, so much. As Nicole mentioned, I want to reiterate that we are not the experts on Act 41 here at the Pennsylvania Coalition for Oral Health. But because of the last minute change, we're going to do our best to just provide a little bit of information around Act 41 and also, kind of collect if there's any thoughts or questions that you have that need to be addressed by the Bureau of Professional and Occupational Affairs, which is the agency that manages our State Board of Dentistry. We will be able to reach out and gather some answers and hopefully get you some information if there are any changes. So we're going to go ahead and just go through a few quick slides on this before we get to our great speakers, just to give you an idea of kind of what we're talking about when we talk about license portability that's currently in place in Pennsylvania. So, as you can see, we have a few different ways that our state recognizes license portability. And I'm not going to read through all of these, but you'll have the slides afterwards, so you can dive in a little closer if you'd like to. But, we look at basically licensed by reciprocity, meaning, the other state has similar requirements. We have an agreement. We agree that we accept what they've got. Endorsement, is when we see the situation where it might be more one-sided. And so that's something that comes into play when we have these discussions as well. When we specifically mention Act 41 and what that means, we're going to talk for a second about the history of that. But basically, there's just a series of procedures or requirements that an out-of-state applicant can go through under this act that would allow them to get a Pennsylvania license that may not be the typical process. And then the last piece, provisional license, I do want to just mention this. It's not something that our State Board of Dentistry does often or on a regular basis, but it is part of the Act 41 requirements that each individual board can make a decision as to if they want to grant provisional licenses during the approval process. So when we talk about provisional licenses, I just wanted to mention that in case it's a term that you're not as familiar with. Now, a little bit around the history of this act and sort of what it meant for Pennsylvania was that, we wanted to see more reciprocity from other states. We wanted to be able to see people coming and having an easier time and removing those barriers for new residents to come in and provide dental care in our state. So for the entire state, it went into effect in July of 2019. So just before the pandemic, which I think from our perspective as an outside coalition, it really muted it. We didn't have a lot of discussion around this because as the rules were being developed, and you can see that the state gave the boards, a year and a half to get these things put into place. When all of that was happening, it was right during the pandemic. And so we didn't get to lift it up probably nearly as much as we should have. Now, our current status right now is the state board did put some language into the regulations that acknowledge the licensure by credentials or endorsement. And they do review applications on a fairly regular basis. I think the way the rules state is that we look at, how often and if it's being done between meetings, because the board meets every 2 months. And it is being done on a regular basis. So the last thing we included on this slide, and that link will be clickable when you get the materials afterwards, is an executive order that was signed about a year ago from our Governor Shapiro, who really saw this as an issue and really wanted to make sure that people weren't waiting months and months to have licenses approved. So he directed all of the boards to compile data on, who's reviewing licenses, how many are coming in, how often the turnaround is, and also stated that if a license couldn't be approved or denied within a certain time frame, that the boards would have to return the application fee to the person, which, so all of our state boards right now are kind of working through this process. And we're waiting for the State Board of Dentistry to sort of get all of those numbers finalized. But wanted to just point out that there is an active process for how our state's working through this right now. Then the piece around, what does Act 41 really mean? It's basically saying if you're coming from a state that we don't already have an agreement with or reciprocity, that there's another way to apply for licensure. And so there's a review of all of your competencies and, what exams you've taken, how long you've been practicing, where you went to school. And then the state is able to sort of accept folks on a case-by-case basis. And so it's something that, again, it's been in play for the last few years, and we're still kind of fleshing out the numbers on what that's looked like so far. So the last piece before I share just a couple of the resources was just some of the language that within our State Board of Dentistry, specifically what it says and what the options are. so that, if we're looking at criteria approval by licensure requirements or criteria approval by reciprocal state certification, these are the different ways that applicants from out of state can submit information and get a license in the Commonwealth without having to go through the entire initial application process. I will say that the fees are the same regardless of whether you're a new grad coming out of school, or a dentist that's been practicing in another state for 20 years. It's $235 for dentists, $140 for hygienists, and that fee is the same regardless. Because I know finances and fees are things that come up, so we wanted to make sure we included that with the current discussion on what's happening in Pennsylvania. And then the last slide, before we move on to Dr. G and the information from AADB, is that I wanted to make sure we included some information that you guys could review afterwards and links to where things are actually stated in the dental regs and the laws right now. So you'll see there's a link to the full text of the bill from Act 41. There's a page that all of our state boards have that is a nice licensure snapshot, which gives you some of the data on what we're looking at right now. And then, of course, our PA State Board of Dentistry page, which links to the regulations. The very small print on there, and that's purposeful. I wanted to be able to include it, but I don't expect you to be able to read it. Was the actual language that was added to the State Board of Dentistry regulations as a result of Act 41. So you can read through that. It was amended May of 2000. And that's something that, kind of just gives you the history of where they were kind of going with it and what we're looking at right now, which I think is a kind of a good segue into the two options that are being presented to us today. Right, Nicole?
Absolutely. And thank you, Helen, for that overview and really kind of putting that together with us. Again, we will be sharing this information, so all of the links that Helen included will be active when we share out this information. And as she mentioned, if there are any specific questions on Act 41 that you would like to have answered today, we can follow up with the BPOA on that. So drop those questions in the chat. But we are ready to move on to our next topic, which is the use of an interstate compact. Now, this is not something that's necessarily new as a policy solution in the United States. However, the exploration of including the dental profession in an occupational licensure compact is fairly new. Our next speaker is the Vice President of the American Association of Dental Boards, and Dr. G will be discussing the AADB's proposed dental and dental hygiene licensure compact. So Dr. G, when you are ready, we are very excited to hear about what you have to share.
Thank you very much. Welcome, everyone. Thank you for allowing me this opportunity. I represent the AADB compact, so this is what we're going to be discussing. Next slide, please. Who is the AADB? That's us. We are an association, a national association of dental boards, and we represent all the dental boards in the United States, their jurisdictions, as well as individual members of current and past. And our obligation is to promote, assist dental boards, and their obligation to protect the public. Next slide, please. Next slide, next slide. Okay, and so this is our leadership, and AADB, for the record, fully supports portability, but with accountability. We are, after all, representing dental boards. And that is a well-trained, standardized, tested, well-qualified dentist or dental hygienist. Next slide, please. So who is AADB? Well, we represent dental boards, and we have had an organization since 1883. And our organization, if you will, has had a grant from the Department of Health and Human Resources and Health and Human Resource Service Administration that we provide a clearinghouse for dental boards. This is the same as the National Data Bank, and it is, however, more detailed. Next slide, please. We also do a composite, which is an evaluation of all dental boards, their actions, their disciplinary activities, complete statistics, as well as legislative actions. Next slide, please. So that's what we do, and that's what we represent. So let's talk about timelines about the compact. So the compact was really initiated in March of 2021. And when you look at this compact, it was a grant the DoD provided for the Interstate Compact. Next slide, please. So when you look at the CSG slide, and this is right from Mark's slide production, and it shows that the AADB was very committed to being involved, but it showed also that we were invited, but we had declined to participate. Next slide, please. We refute that particular issue because we have a letter from January in 2021 from our then president, Dr. Zeta, and we wish full collaboration, involvement, and directly to be involved with the CSG. However, it was actually them that declined our involvement. Next slide, please. And so we were told that there are already several dental boards represented and that the national AADB was not necessary to be involved. So again, a slide directly from the CSG. Next slide, please. And we were also told that the involvement of the DDH Dental Compact could not be changed. It was immutable. Next slide, please. So we did invite the CSG at every annual and midwinter meeting. Next slide, please. We asked them to be speakers, to be involved, to collaborate and discuss. Move forward again. Next slide. And therefore, at January of 23, this is again a slide from CSG, that a finalized compact draft was then provided. Next slide, please. Once we looked at it, we were again told that this is an immutable process. There could be no changes. Next slide, please. So we're looking at an ideal compact, and the view of the AADB as well as others is that portability is critical, but also critical was protection of the public, no increase in fees, and to maintain the state sovereignty. Next slide, please. And so when we looked at the CSG compact, these are the issues we had. We were shocked and surprised that it did not follow the medical compact model, which had been well established, and certainly the equal of dentistry. We were concerned the fact that you did not need a quote unquote license. There was no uniform examination process. There was an unknown fiscal impact. And there are several disparate issues that were just too difficult to detail. Next slide, please. So when we looked at our original compact, the ideal compact, we really had questions about protection of the public, the issue of maintaining sovereignty, and should it not increase licensing fees. Next slide, please. So with that result and the immutability of the CSG compact, we developed an AADB compact. This compact was from all of the involved states, and it included some of the states that were in the original CSG group. We're talking about North Carolina, Washington State, even Texas. And it was in order to do this second compact for us is to correct some of the what we perceived flaws in the CSG compact. Next slide, please. So the medical compact is the compact that we emulated. We followed it to the detail. And the compact for the medicine is from the Federation of State Medical Boards, which was consistent with the AADB. And this was established in April of 2017. So it's been a well-established compact. It's served very well. Next slide, please. So this is a license-based compact. You are issued a license from the individual state. You have a real license. You do not have a compact license. This is a license. Next slide, please. So the requirements of the medical compact, and I'm going to go into this very briefly, is that you have to graduate from a accredited medical school. You have to pass a standardized examination, the USMLE. You have to have a residency, and you have to complete a residency that also requires a board certification. Next slide. But one of the additional requirements is that you have no history of a disciplinary action toward your medical license at all. This is criminal. This has to do with the investigations. It has to be dealing with substance abuse as well. Next slide. So from the standpoint of medical compact, this functions as an original source verification process. These are the standards of the highest denominator. We are talking about to belong to the compact and be able to go to any state you want to practice in automatically, we are guaranteeing that in our compact that that person is a person of the highest quality. There are nothing against, and this would be an automatic approval by your state board naturally. If that person were to apply to your state, it'll be crystal clean, and you would say, hey, automatic. Next slide, please. So when we looked at this compact, the CSGs more carefully, next slide, please. We had the issues. These states were providing privileged models. We didn't understand that. What is a privileged model? Next slide, please. So in our opinion, and this is the opinion of the Attorneys Roundtable of the ADB, including multiple other attorneys across the United States, they're saying is a privilege is not a license. In fact, every other healthcare provider that has a compact states somewhere about a license. It could be a privilege license, a license privilege, but it states license. This is the only compact in healthcare that has no wording of the license anywhere. It only says privilege. Next slide, please. You only need a license from a state, any state, at which point, if that state belongs to a compact, then you have a privilege to any other state that's in the compact. Next slide, please. So one of the issues we had is that it is paramount that you pass a national board examination by the Joint Commission. In the compact of the CSG, the wording is slightly changed. It says, or another examination accepted by commission rule. This means that the compact commission dictates what may or may not be a standardized national exam. Next slide, please. It also talks about predoctoral education. Well, every state by statute requires a CODA accredited dental school. But in this compact, it also states, or another accrediting agency recognized by the Department of Education. For your edification, I am a past chair of CODA, and therefore I am very familiar with accreditation processes. The appropriate legislative and legal language, if you're concerned about CODA going away, would be a Commission on Dental Accreditation or its successor. Another accrediting agency opens the door widely to allow other dental schools that don't have CODA approval to be participants. And this is a really difficult issue for us. Next slide, please. This is the actual language for the CSG. And if you look at the bottom line, this is the particular concern, and this is a clinical assessment versus a clinical examination. Next slide, please. Let's kind of open it up. Next slide, please. This is again the national board. This is also again CODA. Next slide, please. So this is a clinical assessment. It's a process. This is by CSG. And what it is stating that it's evidence of clinical competency in dentistry through a process. It clearly is not a hand skill or psychomotor examination. Dentistry by itself is a profession of motor skills. It needs to be tested. It needs to be tested by a third party. And this allows for, if you will, a standardization across the board of the quality and the training. Next slide, please. When we look at the commission, we're looking at what is this commission that the CSG has. Next slide, please. Next slide, we just talked about clinical assessment. Next slide. So the commission may levy or actually collect fees. And when you look at this slide, you can see that the commission can elect fees, but clearly the annual assessment amount for participants shall be allocated based on the formula by the commission. So there is an untold, unknown fiscal impact because it's actually created by the commission and not by any other organization. Next slide, please. This CSG is allowed to lease, repurchase, retain, hold property, sell, mortgage, and actually borrow money. Next slide, please. And it has a rule that carries the force of law in participating states, which is a little unusual for an organization. Next slide, please. So the solution that we have, of course, is the ADB compact. So next slide. And we define dentistry as a very specifically. Next slide. And we are saying that you have to graduate from a code accredited dental school. And we would say, or a successor, but it has to be a code accredited dental school. We require passing a third-party and national examination as a psychomotor. And we have chosen ADEX as that examination. You must pass the Joint Commission National Dental Examination from dental school, and you must hold a current unrestricted dental license. Next slide, please. And that's an unrestricted dental license. So this is the wording of the AADB. It just states what I have just said. Next slide, please. And the reason we chose ADEX, and many have said, why choose ADEX? Well, we went to the ADA website. We contacted the ADA directly, and we looked at initial licensure. And of the initial licensure requirements per state, 50 of the 53 licensing jurisdictions have a common licensure requirement, and that's ADEX. There are other hands-on motor skill examiners as well, but they were not 50 of the 53. So the largest number was ADEX. That's why we chose ADEX. Next slide, please. Our rule function, we also have a commission. We need to do day-to-day, if you will, administrative work. Next slide, please. Next slide, okay. Next slide. Next one. There are no fees to the state. The fees are paid by the dentist and dental hygienist using the compact for the expedited process. Next slide. We utilize the state dental board portals and databases of every jurisdiction. We already have the clearinghouse. We have the databases. So we just went through an overhaul of our security. We have if you said, a composite, and we have a repository. So it's already built in. We did not have to build a system that the CSG would have to build, would be part of their cost. Next slide, please. So when you look at the issues, some of the issues came up as disparity issues. If you will, CSG has a cumbered license issue that allows for licensees who have some issues with their license to participate in the compact. We do not. You cannot have a active license, and it has to be in the current license as well. And so we don't have a privilege, we have a license. Next slide, please. One of the big issues we have in a privilege, just to bring up an issue, is that if you have a state license as an AADB, then you would follow all the rules of that particular state, including CE requirements. If you read carefully the CSG compact on privilege, you are only required to follow the requirements of your original license. You do not have to follow any of the requirements in a state that you have a compact privilege in. We have real concerns about the definition of privilege, and I'll go into that very quickly. And that is the fact is, what is a privilege? I mean, that privilege will be an issue because it has to be defined. There's no such thing. And if you define the privilege, then you will have some concerns about can a privileged dentist oversee a dental hygienist? Because we know every state says you have to be a licensed dentist. Can a privilege have an anesthesia permit? Because you used to have to. So those are the issues we have with privilege. Next slide, please. So these are the questions we have, and these are the answers we have, and I have them before you. I know my time is very short here. Next slide for me, please. And so when we look at the ADB advantages, we're looking at, yes, portability, but we are looking at also patient safety and the quality of the person practicing your state. And they are totally responsible to you in your state because they have your license. Everything in your state that's required of every other person in your practice would be required of a compact licensee through AADB. Next slide. This also, we have in our commission, the difference is we have 2 representatives. I know CSG has 1 representative, and ours would hopefully would include a hygienist as well. So they're well represented in our compact commission. Next slide. And that is my presentation, and I'll be open for any questions, and certainly I will respond to the projected questions. Thank you very much.
Thank you, Dr. G. I know we're just beginning to kind of scratch the surface on some of these topics when we look at each of these different compact models. So again, please make sure if there was something that, any of our presenters have touched on that you would like more information about, drop those questions using our Q&A feature down at the bottom, and we will make sure that, we can answer them either through our Q&A session or after the fact. So thank you, Dr. G. Our next presenter will also be discussing a different compact model. So please welcome Mr. Matt Schaefer, the Deputy Director of the National Center for Interstate Compacts at the Council of State Governments, as he discusses the Dentist and Dental Hygienist Compact.
Good afternoon, everyone. Thank you for the opportunity and happy to be here presenting on the Dentist and Dental Hygienist Compact that CSG facilitated the development process for in partnership with the American Dental Association and the American Dental Hygienist Association. On the next slide, you'll see just a little bit of information about the policy program at the Council of State Governments that works on interstate compacts. We're called the National Center for Interstate Compacts. We've been around for about 20 years, and we've been involved in facilitating the development process for all of the active licensure compacts, including the medical compact in partnership with FSMB. And you can see there the full list on the next slide of all of the compacts that exist and the partner organizations that we've worked with. So licensure compacts fundamentally are about facilitating multi-state practice. So rather than having a licensee to have to acquire multiple licenses to work in multiple states, the compact is a streamlined pathway to practicing in multiple states without having to navigate each state-specific licensure process. We always mention that compacts maintain or improve public health and safety. This is largely down to the amount of information sharing that occurs amongst the member states. Things like current investigations and adverse actions, all that is shared amongst the member states, and improving the information that regulators have access to. And then lastly, preservation over state authority over professional licensing. So the states retaining their control over their Practice Act, they're retaining control over their licensure requirements. This is just an alternative optional pathway if somebody wants to be mobile or work in multiple states. So you can see there almost all states have adopted at least one of these compacts, and we're almost at 300 pieces of compact legislation just in the past 7 years. And there's 15 professions that currently have these in place. Next slide, please. Okay, so here's the full list that I mentioned of all of the licensure compacts that exist, and you'll notice that most of these are in healthcare professions, allied health professions. We are starting to move into non-health space with compacts like cosmetology and teaching. But you can also see the lead organization that we partnered with on the development of the compact. You can see there the American Dental Association and American Dental Hygienist Association for the DDH compact. Next slide, please. We went over that one. Yes. Okay, so this is the slide that Dr. G shared in his presentation, but just to talk a little bit about the development process. So CSG invited all of the national dental organizations together in 2019 to initially pitch this concept of an interstate compact. In 2021, the ADA and ADHA responded to a grant program that CSG had with the Department of Defense to fund new licensure compacts. And you can see there the list of organizations that signed on to the ADA's application to support the effort. The first step in this process was convening a broad group of stakeholders that we call the Technical Assistance Group, folks from dental education, active licensees, dentists who sat on dental boards, and also dental board executive directors and administrators. And you can see there the list of dental boards who participated on that particular working group. Next slide, please. The next step in the process was to convene a smaller group that had expertise in legislative drafting. So that was mostly board attorneys and board staff. And again, you can see there the dental boards that participated on that committee. We held a public comment period, and where the draft was available for over 8 weeks, and we received over 400 comments during that period. I will emphasize here that AADB was certainly not cut out from participating in this process. We received no public comment from AADB while the draft was publicly available. So it's not entirely accurate that the language was immutable and not able to be amended. We took all of the comments that we received during that public comment period and made changes to the compact as necessary before the draft was finalized in January, as you can see there. Next slide. Okay, so some commonly used terms that you'll see in the compact. So a participating state is just any state that has enacted the compact. A qualifying license is an active, unencumbered license issued by a state that's in the compact. A remote state is a state where you're seeking to practice where you do not hold a license. A compact privilege is legal authorization granted to practice in a single remote state. So that's the thing that the dentist or hygienist is applying to receive that grants them authorization to work in that remote state. And then the Compact Commission is just the governing body that implements and administers the compact. This is made up of the member states themselves. So this is not the CSG compact. This is not the ADA compact. This compact belongs to the member states, and they'll be the ones who implement and administer the compact on an ongoing basis. Next slide. Okay, so at a very high level, here's how the compact works. So a dentist or hygienist would hold a qualifying license, again, active and unencumbered. They'll undergo a background check. They'll pay fees related to the application to the remote state and also to the commission. Complete any necessary jurisprudence requirement. So if your state has like a laws and rules exam or something like that, you'd have to satisfy that. And then the privilege will be issued and you now have legal authorization to work in that remote state where you hold a compact privilege. And the key differentiator here, you may be looking at this slide and thinking, well, how is this even different from the traditional licensure process? And the key differentiator here is time of issuance, the speed that somebody can get access to another state via the compact. Because you're only being vetted one time on the front end, your state of licensure is verifying that you meet all the eligibility requirements, that you pass the background check. Once you're in the system, your ability to obtain subsequent compact privileges is very streamlined. So you're not having to re-verify your credentials over and over again like you would in the environment today, where you're having to resubmit transcripts and exam scores in proof of licensure in another state. There would be no need for that. And so the PT Compact, for example, says on their website, they can issue a compact privilege in 10 minutes. So you're moving from a scenario where you're waiting weeks or potentially months on a licensing board to make a decision to being able to get access to a remote state in a matter of minutes through the compact. Next slide, please. Okay, so just to summarize some of the key requirements here, and this is requirements that the dentist would need to satisfy. So number one, you have to have a qualifying license. So again, active and unencumbered. You have to pass your national board exams. I'll speak to the point that Dr. G made about the language about or another examination. This again is just to keep the compact evergreen. Our intention is that the compact would exist for a generation. And so if there was some new exam 30 years from now down the road, we don't want to have to ask all of the states to reenact the statute over again to account for this change. So we give the commission the flexibility to be able to approve a new national board exam if one ever arose. You have to have CODA accredited education, and that's pre-doctoral dental education. So like a CODA accredited residency program wouldn't satisfy this requirement. And I'll again speak to Dr. G's point about this particular language in our compact. It's not only accounting for a successor organization for CODA, but again, we can't possibly imagine what dental education will look like 30, 40, 50 years from now. If there is some new accrediting body out there 40 years from now that states are using for licensure purposes, the compact can be flexible to evolve with the profession as it grows throughout the decade. So that's the intention here. There's no intention for the commission to be able to approve foreign trained licensee applicants. That's certainly not the intention here. Successful completion of a clinical assessment. This definition is broad and meant to encompass multiple pathways to licensure. So unlike the AADB compact, which is limited to you having completed the 8X exam, if you took the credits exam or CERTA or did the computer-based DLOSCI examination, this would all satisfy this requirement for clinical assessment, or if you did a PGY1 residency. So because there's multiple licensure pathways out there that are valid and reliable and approved by states for licensure, we didn't want to limit the compact of being specific to only one particular pathway. And then successful completion of a background check. Next slide. Okay, so we can talk about benefits here very briefly. Obviously, the primary benefit is facilitating multi-state practice, your ability to practice in other member states without having to navigate that state's licensure process. That comes with potentially retesting or additional schooling, paying duplicative fees. The compact would eliminate that. If you're changing a residency, you wouldn't have to get a license in the new state where you're moving to, but you could just obtain a compact privilege and maintain your previous license, which in turn expands employment opportunities into new markets. I talked about why DoD cares about this issue, supporting their military families, in particular spouses who are highly mobile. And then you're no longer having to retain multiple licenses, which comes with paying duplicative renewal fees. And so it's a reduced financial burden and a reduced burden as well in terms of completing additional CEs in every state where you want to practice. Next slide. Benefits to dental board. So reduction in administrative burden. The state is no longer having to process as many out-of-state applications. So there's a reduction in their administrative burden associated with verifying all of those out-of-state applicants. Ensures retention over practitioners working in their state. So this is a really important point to make, that the Pennsylvania Dental Board retains jurisdiction over anyone practicing in Pennsylvania, whether that's through a compact privilege or a Pennsylvania license. So regardless of how they're authorized to practice in the state, the state retains jurisdiction over their practice, and Pennsylvania can fine, suspend, revoke, discipline somebody with the privilege just as if they held a license. And then I mentioned the point about information sharing amongst the member states. And so the compact facilitates information exchange through a shared data system where all the member states will be feeding up information into that system. Things like availability of significant investigative information, any kind of final board order or action taken against the licensee, all that would be shared amongst the member states and really be a safeguard against bad actors hopping from state to state undetected. Next slide. States really like these, particularly state legislators, as a workforce development tool. So we hear all the time about shortages in oral health care, particularly in rural areas and with dental hygiene. And so the compact is a solution that states can explore to help alleviate some of these shortage areas. Next slide. Okay, so let's talk about adverse action. That's a common question that we get. How does the compact deal with bad actors? So if you violate the Practice Act in your state of licensure, that state takes an action on the qualifying license, you no longer have an active and unencumbered license, so your ability to get compact privileges is automatically suspended. Your active privileges are suspended, and your ability to get new privileges is suspended because you no longer have an active and unencumbered license. So your license would need to be restored to good standing before your privileges could be restored. Next slide. If the action occurs in the remote state, that remote state would take the lead on conducting the investigation. They would be the ones to take an action on that compact privilege that's specific to their state. And then there's a trickle down effect where all of the other compact privileges are then suspended as well until that privilege, the initial privilege that was acted upon, is restored to good standing. And again, all this information is shared via the member states in the data system. Next slide. Okay, I wanted to speak to the Compact Commission. So a couple of times in Dr. G's presentation, he was insinuating that CSG would somehow be responsible for this commission, and that's just not the case. So the commission is made up of the member states themselves, and the language from the compact says that it's the a representative from the state licensing authority. So it's the dental boards themselves who will implement and administer this compact. Now, CSG has a role in helping stand up the commission. We're talking about a new government agency that's being created. So CSG helps staff that commission initially, but eventually all the compact commissions are independent and make their own decisions, and CSG has no role, no outside entity really has a role in influencing this commission at all. And so the commission rules are strictly limited to the implementation of the compact. There could never be a commission rule that goes outside of those bounds and impacts all licensees or anyone seeking not to use the compact. That's strictly outside of the bounds of what the commission is authorized to do. And again, the commission is important because we don't want to have to ask state legislatures to readopt the compact every time there's a change. And so we give the commission the ability to be flexible and make those changes in the future through the rulemaking process. So it's very much like policy making in states works, where the legislature has an authorizing statute and then state agencies and boards are the ones that implement through the rulemaking process. A very similar structure. Next slide. Some additional points of emphasis here. Again, this is just a additional optional pathway to practice. Any current licensure pathway that exists will continue to exist. So all of those pathways that were outlined from Act 41, those would continue to exist. This is not some takeover of what already exists in Pennsylvania. The privilege model is tried and true. It's been utilized by a number of other healthcare professions, including physical therapy and psychology. We've heard several times up to this point that this compact is modeled after the cosmetology compact, and that's just absolutely not true at all. There's virtually no similarities between the two. But the privilege model has been utilized in healthcare professions for as long as the medical compact has, and so it's not true that the privilege has been untested or there's questions around the validity of the privilege model. There's not likely to be significant cost to the states to participate. Really, the only cost would be ensuring that your state's data system can interface with the commission system, and then paying for your state's chosen commissioner to attend the annual compact commission meeting. It's certainly there is language in the compact for a state to be assessed a fee, but that's rare. Only 2 out of the 15 compacts that exist have actually utilized that language and assess their member states a fee. Nursing is $6,000 annually, and SIPACT is $10 per compact privilege that has been issued. States retain sovereignty over their Dental Practice Act and discipline of practitioners within their borders. We've made that point previously. And this compact will be active when 7 states enact it. And on the next slide, we can see a map of where we're at currently with legislation. And so you can see there, we actually just this morning added a 4th member state, and that is Wisconsin. So Wisconsin is compact member state number 4. They just signed their legislation this morning. So this map is a little outdated, but we have bills currently in 13 states, and would certainly will anticipate that we will hit that 7-state threshold very soon, probably within the next 2 to 3 months. So with that, I will wrap up, and we can transition into the Q&A portion. So again, thank you for your time, and happy to answer questions.
Thank you, Matt. And thank you to all of our speakers today. We definitely have heard a lot of information on the role of compact models and their potential impacts on license portability, specifically on the dental workforce and the profession. So with that, there have been a lot of questions in the chat. Feel free to keep